Welcome to my YouTube channel. Today we are going to talk about preterm labor. So the WH definition of preterm labor is when we have regular contraction and which are associated with cervical changes. These two characteristics must be present for you to define preterm labor. So you must have regular contractions and you must have cervical changes. That is the dilatation and effacement of the cervix. And the period that this preterm usually occur is usually between 20 weeks and 37 weeks. This is according to WHO criteria because the definition of viability usually starts according to WHO at 20 weeks. And at 37 week, if labor occurs past that 7 weeks, then that will call it normal labor. So preterm labor is defined by the onset of labor after gestational viability, that is 20 weeks, and before that 7 weeks of completed week. And this onset of labor, what must be present? Regular contractions and cervical changes must be present. And what is the duration at which preterm occurs? 20 to 37 weeks. So threatened preterm labor is defined by the presence of uterine contractions, however, in absence of cervical changes. So we don't have cervical effacements or cervical dilatation. If we don't have that, but we have uterine contractions, then we define that as threatened preterm labor. Classification of preterm birth. So classification of preterm birth, we say already preterm birth is when you have infant being born before 34 weeks. So we categorize it according to WHO. We said 20 to 37 completed weeks. And then now we have three categories. The first one is late or moderate pre-infant. Preterm infant, this is when the infant is born between 32 and 36 completed weeks of gestation. And then now we have very preterm infant. This is an infant born before 32 completed weeks, meaning that is 28 to 32. And then now we have extremely preterm, where it's less than 28 weeks of gestation. So the pathophysiology behind preterm labor, we usually have four pathways resulting to preterm labor. And the first pathway is activation of maternal fetal HPA axis. And this is when, for example, you have maternal or fetal stress, which will later result to production of cortisol, which will later increase the production of production of prostaglandins, and later lead to premature onset of physiological initiators of preterm labor. So you can also have inflammation, which one of the reason is infection, and this, in addition to that, chorion decidual activation and systemic infection, or systemic inflammation. So this usually results to the chorion-decidual activation. And then we have decidual hemorrhage, such as abruption. When you have decidual hemorrhage, then you will have increased separation between the decidua and the chorion, initiating preterm labor. In addition to that, we also have physiological uterine distension. This is in cases where you have multiple pregnancies, you have polyhydramnias, or fetal anomaly. And then, in addition to that, you also have chorion and decidual activation. So chorion is the part of the fetus, and decidual is the part of the mother. Sorry, the part of the mother. So this is the composition of the placenta. So after all that, you will have increased predisposition of premature rupture of membranes, and that will also increase the risk of you having preterm labor. And we define preterm labor as two definitions, where you have uterine contractions and cervical changes. So in terms, the etiology actually is not usually unsolved. However, the cause 50% is never determined. We already, as I said before, we have four different pathways that have been identified that can result in preterm labor, and one or more than one pathways can be activated at the same time and leading to preterm labor. So the pathways, when we mentioned before, we have, this is, you should now be recapping. We said there are four of them, so right now you should be recapping. We have inflammation, and one of the examples we gave is infection, such as a UTI. Then another one is activation of the maternal fetal hypothalamic pituitary adrenal axis, which will result in production of cortisol, which will increase production of prostaglandins, and later we have preterm labor. So in addition to that, we also say decidual hemorrhage, such as abruption, and then lastly, uterine distension. This is stretching where you have polyhydramnias, or you have multiple gestation, a big baby, among other factors. So the etiology, about 50%, the cause of preterm is known, but it's often multifactorial. The following are, however, related to the increased incidence of preterm labor, what we are going to talk in the next slides. Risk factors, these are very important in terms of the history taking. So these are the questions that you'll be asking if a patient comes in and you suspect that they have preterm labor. So the first one, you'll ask if they have previous history of induced or spontaneous abortion, or they have had a previous history of preterm delivery. The next thing you're going to ask is this pregnancy following an assisted reproductive technology? And in these terms of pregnancy, you have a higher risk of having multiple gestation. And if you remember what we said, this will predispose to increased uterine distension, which is one of the pathways that will have preterm labor. In addition to that, you'll also have increased risk of microbial colonization of the upper GI tract, which will later lead to inflammation, which will later lead to preterm labor. And couples usually have increased stress among the infertile couple. So our pathway that is maternal to fetal HPA axis, which later will result to preterm labor. You can also have side effects of the superovulation, and increased risks for birth defects have been proposed in this one, which could maybe lead to uterine distension, among other factors. So another question that you're going to ask, or another risk factor, is asymptomatic bacteriuria or recurrent UTI infection. So if a patient comes in, they're having you are suspecting that they have been preterm delivery, and previously they have a history of recurrent UTI. Smoking habits has also been shown to have a higher risk in terms of being a risk factors of preterm labor. In addition to that, low social, economic, and nutritional status, and lastly, maternal stress. So those are the factors that you should note and also be in your mind in terms of clocking. So in addition to that, those factors, these are risk factors in which the complication in present pregnancy. So these are complications in the pregnancy currently we have, which will predispose the patient to having preterm labor. So in terms of maternal, you can have pregnancy complications such as preeclampsia, such as antepartum hemorrhage, premature rupture of membrane, and polyhydramnios. In addition to that, uterine anomalies, which we already talked about. And for example, when you have cervical subfactors is when you have, for example, because you said for preterm labor to occur, you need to have cervical changes, and also you need to have uterine contractions. So if our cervix already has a problem, for example, you have a short cervix, we have an incompetent cervix, then we'll have a higher risk of having preterm labor. So incompetent cervix, cervical surgery such as colonization, and then short cervix as mentioned before. So the genital tract infections, as we said before, this is bacterial vaginosis. It's associated with twofold increased risk of spontaneous preterm birth. So in addition to that, medical and surgical illnesses. Remember when we said inflammation is one of the pathways that usually causes preterm labor, and we said systemic infection, therefore we predispose one to having preterm labor. So that's what we will talk here. So acute fever, acute pyelonephritis, diarrhea, acute appendicitis, toxoplasmosis, abdominal surgery, chronic disease such as hypertension, nephritis, diabetes, decompensated heart failure, and severe anemia. So the fetal factors is when you have multiple pregnancies, as we mentioned before, or the fetus has congenital malformation and intrauterine death. So the placental factors is when you have infarction, then it will lead to decidual and chronic activation. When you have thrombosis, placenta previa, and placenta abruption, which we said this is decidual hemorrhage. And then iatrogenic is when you have to indicate preterm delivery. So this patient came in with another disease, but for example, they are in 34 weeks, but now the patient cannot continue with the pregnancy. Therefore, you have to do a cesarean section or to induce labor. So that is when we mean iatrogenic, that the doctors is the ones who cause. So we start with pregnancy-induced hypertension in cases of gestational hypertension, in cases of preeclampsia, in cases of eclampsia. In addition to that, fetal stress when you have non-reassuring fetal status. In addition to that, intrauterine growth restriction, placenta abruption, uncontrolled diabetes, decompensated heart lesion, and severe anemia, and intrauterine demise. So the next factors is just a repetition of what we have been talking about in addition to some of the points. So non-white phrase, previous preterm labor, in addition to with spontaneous or induced abortion, low body mass index, extreme ages that is greater than 35, strenuous work, stress, tobacco use, hemoglobin less than 10, bacteriuria or infections such as UTI, low socioeconomic status. So in terms of signs and symptoms, So I need you to tell me by now, even we don't need to do the signs and symptoms because you already said it. We see what are the two components of preterm labor. What are they? You need to have regular contractions and you need to have cervical changes. And cervical changes could be cervical effacement or dilatation. So persistent contractions, which could be painful and painless and associated with cervical changes. That is the main. If you forget everything, do not forget the definition of preterm labor. It's just this and the duration. So intermittent abdominal cramping, which you could be associated with pelvic pressure or a backache. In addition to that, increased vaginal discharge, which could also be associated with drainage of liquor and vaginal spotting or bleeding, for example, in terms of cases of abruption. So the biological markers, one of the biological markers we'll talk about is the fetal fibronectin. Fetal fibronectin is a glycoprotein produced by the chorion, and its secretion it's usually in early gestation and just before term labor. So just to say, if it's in early gestation and term labor, meaning if it occurs between early gestation and term labor, then that is abnormal secretion. And that will be a marker of disruption of the chorion amnion and the underlying deciduum, which could be due to inflammation with or without infection. I hope you have understood. So if the test is negative, less than 1% will deliver in the next week or two, and the test is positive, then the risk of preterm delivery on the next week or two is usually 20%. So false positive is when when it is positive, but now you don't have preterm labor. This is when you can have bleeding, rupture of membranes, and a digital cervical examination. False negative is when you will have preterm labor, but it is not positive. It's given negative, so that is false negative, and this one is usually due to lubricant. So and screening of asymptomatic women at low risk is usually not recommended. And then it is useful when symptoms occur between 24 to 34 weeks, which we said this is before in early gestation and just before term. And then when membranes are intact and cervical dilatation is less than 3 centimeters, and when you have short-term prediction of 7 to 14 days. So other biomarkers include salivary estradiol, cortical releasing hormone, relaxin, beta HCG, and alpha fetoprotein. When we were talking about the cervical changes or cervical structural changes that will predispose one to having preterm labor, we mentioned cervical shortening, and a short cervix is usually defined by cervical length of less than 25 millimeters or less at 24 weeks, and this is usually examined either by a clinical digital exam or ultrasound, which could be transabdominally, vaginally, or transperineal. So the diagnosis now of preterm labor, as we said, what are the components of preterm labor? We usually have regular uterine contractions and cervical changes, which could be effacement or dilatation. So this is the occurrence of regular uterine contractions with or without pain, at least one in every 10 minutes. How will you get this? From physical examination and cervical changes, that is effacement greater than 80% and dilatation of greater than 1 millimeters. How will you get this? By digital vaginal examination and the length of the cervix, as we said. So patient will also come in with symptoms such as pelvic pressure, backache, vaginal discharge, or bleeding, which could be as a result of the show. So investigation, you always do a full blood count, urine for routine analysis, that is culture and sensitivities, cervical vaginal swab for culture and fibronectin, ultrasonography for fetal well-being, cervical length and placental localization, and fetal electrolytes and glucose level when tocolytic agents are being used. So one of the management that you're going to use is the tocolytic agents, and you have to take serum electrolytes and glucose levels while administering them, before administering them. Management of preterm labor. The goals of therapy are four of them. Number one, you prevent preterm labor if possible. So you already know the risk factors. So if the risk factors are modifiable, then you prevent them. And there are also other methods at which you can prevent preterm labor. We're going to talk about them: primary, secondary, among others. The next thing is to arrest the preterm labor if possible and if it's not contraindicated. When you arrest is when the preterm labor has already started, so you arrest it so that it cannot progress. And then appropriate management of labor. So this is where you cannot arrest the preterm labor and it has to continue with its natural course. So this is appropriate management of the labor and effective neonatal care, where labor has occurred and already you have the neonate who is premature. So you have to do effective neonatal care. So why are we doing, or why do we have these goals of therapy, which include prevention, arresting, and ensuring good progression of labor, and also appropriate management of a neonate? This is to prevent complications of prematurity, which include respiratory distress, intraventricular hemorrhage, bronchopulmonary dysplasia, patent ductus arteriosus, necrotizing, necrotizing enterocolitis, retinopathy of prematurity, and sepsis. So how do we approach in terms of management? Just to remind you, we say the period of preterm starts at 20 weeks and 37 weeks, 37 completed weeks. So we are going to divide again these pregnancies again according to gestation age. And the patient who comes in to 34, that when they're beginning 34 weeks to 36 and 6 days, weeks of gestation, then you advise the patient or you proceed with normal labor and delivery. However, if the patient comes with less than 34 weeks of gestation, then you consider tocolysis to inhibit uterine contractions, and then administer steroids for lung maturity and prevention of neck and also the intraventricular hemorrhage, and you administer antibiotics for prophylaxis of prom, and in addition to that, for prophylaxis of neonatal sepsis later after the neonatal during the neonatal period. And if a patient comes with less than 32 weeks of gestation, you consider magnesium sulfate for fetal neuroprotection. Role of tocolysis, as we said before, tocolysis that is administered to inhibit uterine contractions. So in the case of premature rupture of, in case of preterm, it allows us to administer corticosteroids, and it allows you to transfer the patient to a tertiary care. In addition to that, it's also used during maternal antenatal surgeries, and it is important in terms of uterine relaxation in external-cephalic version. So the drugs that we use, just say it is not my time, and I for indomethacin, which is an NSAID, and for nifedipine, which is a calcium blocker, M for magnesium sulfate, and T for terbinafine, which is an adrenergic agonist. So the tocolytics, as we just say, this is just a repetition. The beta agonist, which you say terbinafine, these are the doses, and then magnesium sulfate, the doses, antiprostaglandin, which you said indomethacin, and then calcium blockers which is the nifedipine, or you can also use ritodrine. You can also use oxytocin antagonists and nitric oxide donors. So all this, their mechanism of action will later result to inhibition of the uterine contraction. Also, kindly note that in terms of prostaglandins and NSAID, it will, if it is used after 32 weeks, it will usually lead, as a side effect, usually lead to the premature closure of the ductus arteriosus. Next, contraindications to tocolysis is when you have gestation more than 34 weeks, when you have significant vaginal bleeding, suspected fetal asphyxia, intra-amniotic infection, intrauterine demise or lethal anomaly, maternal indication, uncontrolled diabetes, severe anemia, cardiac disease, severe preeclampsia or eclampsia. Although the tocolysis may prolong pregnancy, they don't usually improve the prenatal outcomes, but do have adverse maternal effects. So these drugs usually have the normal side effects of our drugs, and what they'll adverse to the mother. As a rule, they should be given with the corticosteroids, and most do not recommend use of tocolysis, as we said before, in pregnancies that are equal to 34 weeks or are greater than 34 weeks. And then there is no role of maintenance of tocolysis. These tocolysis have to be given within 48 hours. So antenatal corticosteroids, if you remember, we said in pregnancies that are less than 34, we should administer corticosteroids, and the role of corticosteroids is to prevent, for example, lung maturity and to prevent cases like respiratory distress syndrome, in addition to NEG. So it is given to all fetuses between 24 to 34 weeks gestational pregnancy who are at risk of preterm delivery and should be considered. So the decision should not be altered by race, gender, availability of surfactant replacement that I will just give. Those eligible for tocolysis are also eligible for corticosteroids. The optimal benefits usually begin 24 hours after initiation, and then they usually reduce the incidence and severity of RDS, IVH, and NEC. So RDS is respiratory distress syndrome, IV is intraventricular hemorrhage, and NEC is necrotizing enterocolitis. I want you to remember those three of them. Those three of them. When you are given an essay to write, those three must be there: respiratory distress syndrome, intraventricular hemorrhage, and necrotizing enterocolitis. So the drugs that we use is dexamethasone and betamethasone, which can be used. We are going to talk about the dosage in the next slide. So the dosage, betamethasone, it's the typical regimen is two doses. You give them at 12 mg. It's administered intramuscular, 12 hours apart, and total is 24. So total for both betamethasone and dexamethasone is 24. And we say that you have to give them for 24 to achieve 24 hours to achieve optimal benefit, as we talked about in the previous slide. So for betamethasone, we divide them into two doses. This is just very easy to administer, and even for in terms of the nurses. So two doses where you give 12 mgs twice BD for 12 hours. And dexamethasone, divide them into 4 doses where each you give 6 mg. So if you divide 4, so if you multiply 4 times 6, the total will be 24. So it's given intramuscularly every 12 hours, also totaling to 24 mg. So the antibiotics you also have to give, and it is given in all patients in premature labor are considered. So all patients in premature labor are considered to have increased risks of neonatal group B streptococcal sepsis and should receive prophylactic antibiotics regardless of the culture status. So this, if a patient comes in and even if the culture status is negative, of the culture is negative for group B streptococcal, then you still have to give prophylactic antibiotics. And the CDC advised screening of all pregnant women for group B streptococcus at 35 to 37 weeks. They should not be used. This should not be used to prolong gestation or to improve neonatal outcome in women with preterm labor and intact membrane. So the goal actually for giving these antibiotics is to the fetus. It is to the fetus, and it's to prevent neonatal sepsis and not to prevent preterm labor. Remember, the only thing that we can use to kind of arrest the preterm labor is the tocolysis. And we say the mode of action or the result of the mode of action of tocolysis is to inhibit contractions. So if we inhibit contraction, at least it will give us times to give antibiotics and also to give corticosteroids. So delivery, tertiary care center is where you need to deliver these kinds of patients, and you need specialized staff and specialized equipment. The decision whether to do cesarean section or normal delivery, that is vaginal delivery, depends on the type of the patient or the characteristics that the patient has and the risk factors among complications that the patient has. However, CS may be preferred in extreme prematurity. The stages of labor will progress as normal labor, and during the first stage, you usually have the latent and the active phase, which will later result to the dilatation of the cervix. So you put the patient into bed, you ensure adequate oxygenation of the patient, you avoid strong sedatives, and then epidural anesthesia is the anesthesia of choice. Labor should be watched by intensive clinical monitoring, continuous electronic monitoring of the labor, and in case of delay or anticipating traumatic vaginal delivery, then a CS should be performed. In terms of second stage of labor, where we normally have now the delivery of the fetus, the birth should go gentle and slow. Episiotomy may be done under local anesthesia to minimize the head compression, and cord is clamped immediately at birth to prevent hyper. Because this baby is small, then if you allow blood to move from the mother to the fetus, you can have hypervolemia and hyperbilirubinemia to shift the baby to ICU. So care of the preterm, the cord is clamped quickly as I said before, and the cord length is usually kept long. The hair passage should be cleared of mucus promptly and gently. That is to enable adequate oxygenation, and then maintenance of temperature to prevent hypothermia. In addition to that, just as normal newborn, you inject vitamin K. One of our goals of management was prevention of preterm labor, and in terms of prevention, we are going to divide it into two, primary and secondary. So this is to improve the quality of life and nutritional status of the patient, and you ask the patient to reduce physical and emotional stress by encouraging bed rest. You have educational programs for signs and symptoms, and this sounds to include contraction, pelvic pressure, vaginal discharge. Hydrate the patient, make sure the patient is hydrated. Progesterone, which is usually given in second trimester, especially in women who are asymptomatic and have a prior history of preterm labor. And cyclage, which is a procedure which is used to keep the cervix closed and is used to treat cervical incompetency. And diagnosis and treatment of infection such as UTIs, which is said is one of the risk factors, and role in assisted reproductive technology, twins and higher order multiples. So secondary prevention. This is when already the preterm has already started and you're trying to arrest it. So what you can do an emergency cyclage. You can also administer antibiotics as we talked about in the previous slides, and tocolysis, which will prevent uterine contractions. Thank you.